Hello, clinicians, and welcome to today's live event, Improving Outcomes from Addictions. We are live today with Executive Director Liz Means. As we roll into the content today, we want to let you know if you are a clinician and you are here for CEUs, it is super important for you to put your name, your credentials, and your email address below so that we can get you credit for your credentials or for your CEUs. So Liz, welcome today. Why don't you go ahead and, for anybody who doesn't know you, introduce yourself and what you do at A Way Out.
Hi. Is that reverb? There's a... Uh-oh, Danny.
Here we go. One sec. All right.
Okay. Hi, I'm Liz Means, and I'm the Executive Director of A Way Out, which is a nonprofit based on the western slope of Colorado. And we provide individuals and families in crisis with drug and alcohol abuse financial and clinical access to treatment and long-term recovery support. We're pretty dedicated to our mission, and we have helped thousands of individuals and families over the years navigate addiction in the home and recovery within the individual. And we believe in having a lot of fun in recovery, and so we promote that through our alumni program. We have 5 clinicians, a family program, the alumni program, and we have a resource-rich navigation part of our program, which helps individuals find places to help a loved one go to treatment or themselves. And we collaborate just about with everybody in our area and nationally. So we believe in strong collaborative support. And on that note, I really want to acknowledge our sponsors. And our sponsors are truly the ones who made this event happen. This is our first year of a virtual conference. I think we're all doing things differently this year with the pandemic happening. And we really could not have put this conference on without the support of these sponsors who all have excellent treatment programs. So I also wanted to let you know that this is somewhat of an interactive conference. It might be a little bit different than your Zoom. We will be able to ask questions midstream during a presentation, but we will take a very thoughtful break halfway through Dr. Barnes's presentation, and then there will be a Q&A after. So if you have questions, please put them in the chat, and either Danny or myself will make sure those questions are answered to the best of our ability. We love Dr. Barnes. We've had him speak before, but I'd love to introduce to you board member Caroline Kochner, and she is going to talk a little bit about Dr. Barnes. Caroline? Your speaker's off, Caroline.
Hi.
Hi.
I'm Caroline Kochner, and I'm doubly privileged to be a member of the board of directors of A Way Out and to introduce our speaker, Dr. Michael Barnes, today. Dr. Mike Barnes has received a BA in psychology, a PhD in marriage and family therapy, is a nationally certified master addiction counselor, and a licensed professional counselor in Colorado. He is also a diplomate in the American Academy of Experts in Traumatic Stress. His area of clinical and research interest is the impact of traumatic events on family system functioning. As the Chief Clinical Officer at Foundry Treatment Center in Steamboat Springs, Colorado, he is developing, along with his staff, a trauma-integrated treatment process. After hearing Dr. Barnes speak on behalf of A Way Out before, the board eagerly asked him to join our advisory panel, and he gracefully accepted. We are so pleased to have him as part of our organization. As the parent myself of 2 recovering daughters who struggled with addiction and co-occurring disorders, I know firsthand that dealing with a loved one who has been tasked with changing their every reaction to their craving triggers, their recovery does not occur in a vacuum. After hearing Dr. Barnes talk for A Way Out earlier, I realized that for my loved ones to achieve success, I needed to deal with my own trauma-related triggers. The result has been a level of freedom and connection to my children and everyone else I ever met in my whole entire life, for which I am eternally grateful. Dr. Michael Barnes.
Thank you, Caroline. I appreciate that. Thank you for the introduction. So, it's always interesting when you're putting together a presentation, and people know me as a program administrator. I'm the kind of trauma guy at conferences. But I was moving, as many people who have moved around a lot like I have, there are always boxes in the garage that you always wonder every time you pass it, what's in it. And one day I was going through getting ready for another move, and I was looking in this box, and I found a group of papers that I wrote 30 years ago in my doctoral program. And I don't speak very much about the fact that my PhD is in marriage and family therapy. And I went back to school for one reason and one reason only, and that was really to learn how do you work with families where there is chronic addiction, and then the issue that kind of came along was the trauma. So on the first slide, you'll see a paper that I wrote many years ago. I wrote that paper in 1991, and if you can't see the title, but the title is actually Alcoholism Treatment in Residential Settings. Is it time for a systemic paradigm shift? I didn't say shift, but I should have said shift in that. And the idea was, when I found it, I was really kind of looking for what's my next kind of passion project. And this paper has actually stimulated in me a desire to really return almost exclusively to working with families, trauma, and addiction, and working with the Foundry in the process of building new family programs. And so the other thing that's really important about this paper, and if you look at the circle, the date that paper was submitted was December 9th, 1991. 40 days after that paper was submitted, our son was hit by a car and spent 3 weeks in intensive care, and a month, several weeks in the hospital and body casts and all of that. And it was really the beginning of this movement towards trauma and really looking at the relationship between trauma and addiction. And so that's a long explanation to the process. But what really struck me when I read that paper again was that in 30 years, we really haven't changed very much. And so there were three things that really stuck out for me when I reread that paper so many years later. The first is the quote that says, "In this setting, residential treatment, families are invited to participate in treatment for primarily two reasons. First being, and we still do this on a regular basis, to assist the client in breaking through denial, to achieve acceptance of the reality of his or her addiction and the consequences that have directly resulted." And so, to a very large degree in the residential setting, families are our support system. And sometimes, I hate to use the term, but they're the enforcer, the when someone's thinking about leaving, that we can access the family to help that connect to that person to stay in treatment, which is not a treatment objective, but it's certainly utilizing the influence of family to assist the individual. The second one is we teach families. We help them learn about the disease of addiction, how it's affected the entire family, learning about their survival behaviors, symptoms of chemical dependency, enabling. And I have very different views of enabling than many other speakers. I really see enabling as a trauma response, and we'll talk about that a little bit later. So the idea that we don't really treat the family, we support the family. we educate, we coach. And given that the name of this conference is Improving Outcomes from Addiction, it's my opinion, and will be my opinion, that if we really want the outcomes to be improved in the world of addiction, then we better start treating the family as well. So on the next slide, you'll see that the third one was, and this, remember, this was 30 years ago. Regardless of one's opinion concerning the disease concept of alcoholism or addiction, the research indicates that the family is closely associated with aspects of not only the transition or the transmission and maintenance, but they're also very influential in helping that individual kind of get into a lasting recovery. And so given that information, we've made so many advancements in the treatment world, from huge advancements in our understanding of the neuroscience of addiction, improved medical interventions, medication-assisted therapies, integration of trauma into treatment. And while I think the world of coaching families has gotten much better, intervention, the whole world of interventions and helping families in the process of getting someone into treatment has gotten much better. I really don't think we really haven't made a whole lot of progress in the treatment world in our work with families in the 30 years since I wrote that paper. And so, why is that the case? And so I think there are a number of reasons. The first one in my mind is that the client is the client. The family's not the client. And so insurance identifies who the client is. They pay for certain services. And one of the services they don't pay for, they sort of expect in the program to be some kind of family, either education. For adolescents, they expect family therapy. And every program does that a little bit differently. So everyone incorporates family education and family support. And some places really do pretty extensive family therapy as well. The second one is that 42 CFR Part 2, which is the federal confidentiality law, really prohibits us from sharing information with families without the consent of the client. So often families play a peripheral role in the treatment environment, while the client actually limits information that can be shared. And in some cases, that's really valuable. And in other cases, it's really kind of isomorphism, or the idea of we're kind of holding secrets with them that they don't want their family to understand. In some cases, that's to allow the client to work through those issues. In other cases, clients just don't want that information. They don't want people to see the advancement of their illness. The next is the traditional linear view. We still see addiction as a linear process. Person gets it, they impact other people. They don't see it as a systemic influence where every member of the family is impacting every other member of the family. And so I really started thinking, what would happen if we really began to treat addiction as a chronic disease? And what would happen if we really started looking at how chronic disease management within medical environments actually treat families? And the rest of this presentation is really hopefully an answer to that question. So the next slide will show you that I actually went in and looked at the programs that I've worked in over the years, and I've looked at what services we provide to clients, and then I looked at what services we provide to families. And as you can see, there's significant services on both sides, but 40 hours per week are provided for the client and only 30 minutes to 60 minutes per week for the family. And I think that's something that really needs to change. And the other thing, when I look at what's missing, is the level of interaction between clients and their families. And so often clients are really anxious about going home and wondering, they've had lots of phone conversations, but they're really wondering how things are going to be. So if we really begin to look at what chronic disease treatment providers do, is really pretty uniquely different. So the next slide that you'll see, so I think James Rowland is if you're interested in chronic disease maintenance and family, I would say he's the guy to look at. He's He's an adjunct professor at the University of Chicago Medical School. He's an officer in the Chicago Family Therapy with Illness organization. Very, very smart guy. And he's just written another book, or not just, that came out in 2018. So if you're interested, he's the go-to guy. And if you look at the 3 bullets on this slide, you'll see that it's a radically different view. And if the first one, and I highlighted chronic illnesses viewed from a family perspective, but I should have highlighted the individual family member with the illness is no more important than the other members of the family or their social networks. And the idea that if someone we love or someone we care about has a chronic illness, it's going to affect every single person in the family. And I'm going to show you several slides along the way as to how that begins to happen and what are the things that need to get addressed. But it's really important. The idea of, well, I just wish my loved one would get sober so that we can get back to normal, misses that kind of point that we have all been evolving as the illness has progressed in our ways of coping and our emotional, our biopsychosocial response. The second bullet talks about families enter the world of illness and disability without a psychosocial map. They don't know what they're getting into. All they know is what their previous generations before them have done with illness and how that has influenced their perception and their understanding. We'll talk a lot more about that. In that, in order to kind of help the entire system heal, that families have to understand the impact of that condition on everyone. So often siblings are very angry at the addicted family member, and they tend to become the lost children of that system, or they become the family hero of that system. But so often they don't really get their needs met within that system. And so Roland developed a model called the Family Systems Illness Model, very much strengths-based, looks at family relationships as a resource, a non-blaming, non-shaming, how are we going to use the resources that this family has available to them? How are we going to build increased resilience for that family? And so the idea of traditional addiction is we're going to ship this guy out, and then we're going to support the family, guy or woman. But the idea of how do we make sure that everyone gets the services that are needed. And again, I am still very much in support of residential treatment. I think that we can begin, when you see the model that I'm developing, you'll see that it can fit within any level of care. The next is a slide that really looks at, it's interesting. I was doing a lecture for our clients the other day, and we were talking about the chronic disease model, and we were talking about families, and the clients were all like, yeah, we need to really get our families to understand that this is a disease. And when I really started looking around the room, and I said, how many of you really believe it's a disease? And like, even the clients struggled in that area to some degree. They don't really understand what chronic disease means, and the idea that that it's going to be with them forever. And so I started looking at the course of the disease. And again, there are different onsets of chronic diseases. Some are really acute, which means someone has a heart attack and then they are limited. They have certain heart damage, or some other event takes place, a stroke, where there is damage to the biology of the individual that creates a huge crisis for the family. And then the family has to learn how to begin to deal with those limitations that may be with that person forever. And what we find is that it really challenges how the family organizes in a very kind of rapid way. And everyone begins to talk about, well, we need to do these things in order to support dad, or to support mom, or one of any number of family members. Addiction is a very different process. It's gradual onset. And it really, in the long run, allows for a much more gradual adjustment period. But sometimes that adjustment period is almost invisible. And particularly as the progression of the disease is a slow developing progression, a lot of times families don't even realize, and that idea of, well, if he would get sober, we could go back to normal. They don't realize that the normal before the addiction isn't the normal that they're in right now as they're beginning to adjust to this, to the addiction. And that, what they really need to do is go to a newer normal or develop family healing that allows for a completely different normal. And again, no, it's not about fault. It's not about blaming. It's about a family adjustment. In the course, there are 3 different courses of chronic diseases. A progressive disease, and certainly addiction is a progressive disease. A constant course illness, such as a heart attack, stroke, those kinds of things. And the one that I think addiction fits in is that relapsing or episodic course illness, where there are periods of low symptoms and then periods of high symptoms. There are periods of health and then periods of relapse. And even when that individual is in long-term recovery, there is a family stress experienced as they're sort of looking for, hypervigilant of those symptoms that may predict or kind of warn of potential relapse. And so I think the next slide has a mobile on it. So I use that mobile symbol all the time. And I always ask families, when your loved one walks in the front door of your house, how long does it take to determine whether they're impaired or not? And so I've asked hundreds of families over the years, and the average answer is 2 seconds. And so if you think about 2 seconds, that's a pretty hypervigilant process. And when you ask families about that hypervigilance, they talk about the difference of how they have to respond if the person is sober or is not under the influence, and how much more relaxed it can be, or how much more relaxed it is if they're not using than if they are using. And so I used this slide, not because the Jelinek curve is kind of outdated, it's kind of old, but I like the vision of it. And what it is the stepwise progression of how we kind of viewed alcoholism. Jelinek was one of the founding members of the Yale Addiction Studies program, and kind of this curve is the curve of the progression, and then the curve of the progression into recovery. And I show this to say, if you look at, let's just say that from the beginning, occasional relief drinking, till the end, complete defeat or admitted defeat, let's just say that can take a period of years. And so that as that person's illness advances, and as they begin to show increasing symptoms, each member of that family system begins to adjust to it. And so the family medicine folks would say that prior to there being a diagnosis of some form or fashion, that the family is just responding from a state of crisis. They're just going from one symptom group to the next in that process. And so I really want you to kind of get that picture of how intricate, how in some cases minute those changes would be. And the pictures that I've included of each of the members of the family, if you could really drill down, you would see that it has a limbic system and the sort of prefrontal and the kind of brain, and then the ventral vagus nervous system on the side of the face. And so it's not that it's just learned, it's that there are trauma aspects to this for family members. There are kind of biological changes, neural networks that begin to develop. And so much of these shifts that are made, if we remember that about anywhere from 60 to 80% of our the time we're kind of functioning from a place of procedural memory, that these things are beginning to make changes to that individual that they're not even aware of. And so as that person progresses into the depths of their addiction, that family has moved from a pre-addiction normal, if there even was a pre-addiction normal, if those parents, the adults in the family, grew up in addicted families of their own. And so I hope that can, like, that drives it down, like that idea that it is functioning at a neurological level as well as an emotional level and a cognitive level. So if we can go to the next slide, if you think that that progression in the addiction doesn't impact us, this was a research project that I did several years ago when I was at Sarasota Memorial Hospital in Sarasota, Florida. And it was a study where we looked at family members of individuals who had mental health issues and addiction, but we never used the word trauma for any of the study. And I asked them if someone were to call them, a family member, extended family, friend, whatever, and ask, what's it been like to have addiction in your family? Or what's it been like to have mental health issues in your family? And I had 40 hours of transcripts from partners and children of clients and adult children and extended family. And when I coded it, it came through so clearly that there were very common feelings that family members had as they dealt longer and more with their addicted loved ones. Anger, fear, guilt, grief, horror, depression, frustration, shame. Many of those are the same feelings that we work with clients in the residential setting with, having the exact same feelings. Certain defenses, denial, rationalization, intellectualizing. We got to figure out what's going on here. Those are the exact same defenses that clients use in order to manage the emotions and the reality of their addiction. Common cognitive responses: obsession, intrusive thoughts, uncertainty, self-blame, hopelessness, helplessness, and the idea that those are all very common trauma responses for individuals. Common physical responses: sleeplessness, exhaustion, nightmares. It's so common to talk to family members and that they don't sleep very well, and that they're, waiting for that late night phone call. And when something happens, they startle. Again, very common trauma responses. And then the last is common behavioral responses: hypervigilant, waiting for the next issue to happen, controlling themselves and controlling others, caretaking, enabling, those kinds of things. So in the process of coding all of that, it became pretty clear that as family members are making those adjustments to cope with the adjustments being made in the addiction, that they're actually getting kind of traumatized in that process. So if we look at the next slide, which should be the person moving up the other side of the recovery model. And so if we continue to maintain the old standard that it is the client's response, and let me be really clear, it is the client's responsibility to get sober. And I think families can either be supportive of that, but they can at times, because of being where we are in the kind of at the bottom of the other side, the previous slide, it would make sense that as the client is beginning to work through those steps up into recovery, that the family members would benefit from beginning to look at their own circumstances and how they can begin to move into a family healing process as well. And so if we were to ask the family, which I do all the time, your loved one has been sober for 2 years, a year and a half, 2 years, and you haven't seen them for a while. How long before you think you probably should check out to see if there are any warning signs that they're using? And the average answer is 2 seconds. And that idea that, if the client's making that progress and the family is still kind of functioning from that hypervigilant and controlling position, and when I say controlling, I'm really meaning to control so that they can feel okay. That's one of the reasons that I think families and clients struggle. I hope that makes sense, that if you kind of see that progression and how the person's getting sicker in their chronic illness, the family is adjusting to those that illness, and sometimes in really healthy ways and sometimes not healthy ways. And then as that person begins to go into a state of remission or to a state of recovery, that the family generally needs to go with them in that process. So in the next slide, so I talked a little bit about the idea of crisis and chronic. I didn't talk about chronic, but the idea that there is a timeline for chronic diseases. And so this is, like, in my mind, this is really important, in that Roland and his group really began to look at what are the things that families that work successfully through the process of dealing with chronic disease, like what do families do? And then once it's been diagnosed and they move into that chronic phase, and they're kind of worrying about relapse, and they're worrying about, progression of the illness, there's certain things that they do. And so these are the things that families that in a successful way move through this process. Number one, families understand themselves as a system. And the idea that we're in this together, that how we have coped is we've done the best that we can. And that if we continue, and what we find is if they continue to focus on the person with the chronic disease without understanding the influence and really maintaining their focus on everyone else, that they do a process that we call organizing around the addiction. And that keeps the addiction actually more central, and it allows other members of the family to get their needs met less. To look at psychosocial understanding, the biology, the kind of emotional and relational consequences of the illness, and to begin to work on those to make sure that the relationships in the family stay healthy. Family appreciation of individual development and life cycle stages, we'll talk about those here in a few minutes. Make sense of crisis reorganization. We're going to talk about the 5 R's. Create meaning, promotes mastery. And from my research, I've found that perception is way more important to how families function than is reality. And that, there's a couple slides on that later. So grieving losses and learning to live with symptoms. And so on the next slide, if you look at the date on this slide, it's 1989. And this was my mentor. His name is Charles Figley. And he wrote the first book on, and these are from a book called Helping Traumatized Families, I believe is the name of the book. But he wrote the first book on Vietnam veterans and PTSD, etc. But if you look at what he characterized as the signs or the characteristics of families that are most resilient, they're exactly the same things that Roland said in 2013. Accept responsibility for dealing with the situation and mobilizing energy and resources for action. Shifting focus from one family member to the whole family is dealing with a similar problem. Move quickly from blaming to solution. Increasing tolerance and patience. And that was one of the things Roland said at the end. Clearly identify and express emotions, working with that biopsychosocial, spiritual kind of disease process. Allow members to access their own individual and interpersonal resources, reaching out for social support. And that number 6, allowing individuals to kind of reach out to their own resources, is one of the first things that we see as families are reorganizing to deal with crisis, is that they close the boundaries around the system. They become enmeshed so that they can try to control everything and keep everyone safe. But if they don't, that's a very normal process in that crisis phase. But if they don't release that and allow people to kind of go through their life cycle stages, go through their stages of individual development, that we begin to see conflict down the road. So I was talking with Annie Camacho, who is our family director, And she and I were doing this resilience lecture with the guys. And afterwards she said, I've never seen that slide. And I said, yeah, I've been using it for years. And she said, that's exactly what our family program is trying to teach our families. And I said, and I just smiled and said, yeah, that's exactly what we've been trying to put together, this process that helps families to take that next step. So the next slide should be, so there are different theories, and again, we have our mobile. There are different theories about, what's the impact of chronic disease on how the family functions. And I've included 3 of them that I think, these come from a different text, Rees and Steinglass and Howe. And Steinglass wrote the very famous book, The Alcoholic Family. What they said was that the first theory is the impact of chronic illness. The actual illness itself depends less on the impact than the burden that individual family members experience in coping with it. And so the idea that it depends on how debilitated the individual is. And so again, if we look at the mobile, that as one person is impacted and is not able to do the things that they have done before, then relationships are going to change and the configuration of the mobile is going to be different. And in order to maintain that balance, everyone else's behavior has to change as this person exhibits the illness. So the first theory is the type of trauma doesn't, or the type of illness doesn't matter. It's really just how debilitated the individual is and how much burden it poses. The second is symptom patterns and disability. So it's not necessarily the illness, but it's the symptoms that the family is constantly having to adjust to. So as symptoms shift, that it molds the individual and family to that illness in very particular ways. And so with addiction, when we begin to look at dishonesty and betrayal and there's just so many different symptoms, that it's the symptom patterns that people are adjusting to. So if my loved one is struggling with addiction or with trauma, different people in the family who manage or interact with those symptoms in different ways are going to react in different ways. And then the last one, and this is the one that I really adhere to, is that there is a systemic balance of the reactions of individuals in the family. And I think that's why the mobile is such a nice representation, that each person is going to shift in different ways, and that as each person adjusts, like a sibling may react to another sibling that they've been very close to through the development of the addiction in a way that's very different than the parents might. And so system balancing of individual family members' reaction will serve as a regulatory mechanism for stabilizing the management of the illness. Each family member will have a different tolerance for the illness. They'll have a different tolerance for the symptoms, and they'll have a different tolerance for how different family members react. Siblings are often angry with their parents for the way they've managed their loved one. And we can go into great detail with that. So if we look at the next slide, this is what it looks like. And I love this picture because Laurel Kisher is from the University of Maryland in Baltimore, and I do a lot of work in Baltimore with the University of Baltimore. And I've really become really kind of fond of her work, is that if you look at this picture, there's nothing linear. And so if the person with the addiction is one of the adult or parental individuals, it's going to impact everything from how they interact with the children, how the other adult is going to interact with the children, how they're both going to interact with kind of intergenerational responses, grandparents, extended family. That's going to impact how the siblings interact with each other. So the sibling subsystem is going to shift in its rules and roles. Parenting is going to be different. We often see parentified children and those kinds of things. And then adult intimate interactions are going to be different. If it's one of the kids that is struggling with the addiction, it's certainly going to impact how I'll show you a slide in a little bit, how that will impact the family system. And so I show this more than anything for a family member who's saying, I just don't see how this has changed us, to begin to look that in some ways it may be really hidden. But this is what the research would tell us, is that it, in subtle ways, changes the way families interact with each other at every level. And so, again, as we look at that timeline across the bottom, and we look at the mobile on the right-hand side, like individual and family outcomes, as the family adjusts to that, the mobile begins to shift in order to be able to maintain balance. Because if one person continued to get worse and everyone else stayed the same, the system would not stay together into a balanced position. And so on the next slide, these are the things that Roland's family chronic medical illness model begins to look at. And I think this is really important. And so if you've heard me, anyone who's heard me speak before, you will always hear me talking about 3-generation assessment. And the idea of, as we begin to look more at like epigenetics and the transgenerational transmission of, trauma and genetic materials and how the environment alters that, how the family illness and belief system, the schemas that we develop about the safety of our world and the workings of our world are greatly influenced and impacted by this 3-generation interaction or transgenerational interaction in terms of illness and in terms of trauma and in terms of addiction and mental health issues and divorce and abuse and all of those issues. And so how we have shifted, or how we believe an illness actually is, will dictate how we are organized around that. The rules that we have about communicating, the rules that we have about family members' emotions and talking about difficult conversations begins to shift to accommodate this chronic disease. The more we focus on the individual with the chronic disease, the more it alters our family life cycle stages. And I'll show you a slide that will explain that in a little bit. And those life cycle stages, if we're not allowed to do the things that are imperative in our personal and emotional development, then we will have significant developmental struggles. And if we look at the next slide, it's really how I view families. And so that big black cloud in the middle of all of this, it's not just the drinking or the drug use. It's the trauma that's associated with it. Over the course of time, as you look at all of those, those are the symptoms that I see that each member in the family is going to have a different tolerance for. And that, again, how we understand this, how we deal with this, and to a large degree, not to a total degree, but to a significant degree, is really kind of looking at those multiple generations. And how was I raised? Was I raised in a family where addiction was present, but no one talked about it? Did I grow up in a family that had that sort of mentally ill uncle that no one talked about? That kind of thing. And so it's really important to understand that while the client, like addiction, is a breeding ground for trauma, the same can be said for the house, the home. And this could be an entire lecture, just kind of looking at this. But the idea of, if we're working with that much conflict and we're working with that much uncertainty, even with our greatest of intention, we're probably going to have some struggles in those 5 very important developmental areas in our family. And while we and I grew up in a family with addiction. When my grandfather was a chronic alcoholic, and I always thought that we were like the most normal family in the world. And then over time and learning and realizing that there were a lot of these things that did not get addressed as they should have gotten addressed because of dealing with those issues. So sometimes in hindsight, it's actually the old saying of hindsight is 20/20. I think that there's a lot of truth to that. But those are the things that if we're really going to do a family treatment program, it's going to have to address all of those issues, the trauma and the stuff in the middle, as well as each of those areas, to see how much resentment do the other kids in the family have because they didn't get to do the things that they felt that they should have been allowed to do. How many secrets have been held. So we'll talk about this as we go forward. The next slide. So if we're really looking at 3 generations, that's a slide of a family that I worked with years ago. All the names are changed, but they allow me to use this slide. But if you begin to look at how trauma has gone through the client, the young man, 22 years old at the bottom, his mother, Denise, significant trauma, sexual trauma. She was abused by the uncle that is right above her on the genogram. She was also physically injured as a child and had an amputation. She had significant health problems. She grew up in a family where dad was a combat veteran and mother was a trauma survivor, certainly physical trauma from the veteran dad. And so this young man had been in treatment multiple times. And this was back in, had to be the 90s. And if you look at his father's side, it's rageaholicism and alcoholism on those families. And we really began to look at, if this kid has been in treatment multiple times, the major trauma for this kid, other than living in a family that had an alcoholic father and severe traumatized mother, was that he and his sister were crossing the street when he was 16 and she was 12. And he stepped out onto the street and he looked to his left and saw a car coming, and he stepped back and she didn't, and she was hit and killed in front of him. And so we really began to look, long before there was ever such a concept of trauma-informed or trauma-integrated work, was to begin to look at what has been interfering with this kid getting sober over the years that he's been in treatment. And so we did this genogram and really began to look at what needs to be healed, what relationships need to be altered. And so as we begin to look at the impact of epigenetics and attachment, think of all the work that's being done with ACEs, adverse childhood events, and the idea of if you grow up in a family where there is significant trauma, abandonment, neglect, abuse, mental health issues, how individuals experience their own significant medical complications, the very high likelihood of that person becoming chemically dependent themselves. So a lot of times families don't want to look at this. It's painful. It's difficult. They sometimes feel blamed in that process. And that is never my intention. Never my intention. And so, but the more a family, it's so interesting to do a genogram when one of the family members comes out and says a secret that no one knew. And everyone looks at him like, are you kidding? And that idea of maybe things aren't the way we always thought they were. It's a really powerful way to do that. And then
All right, Dr. Barnes. Hey, I just want I want to pop on real quick just to let everybody know that we are going to break in the next 5 to 7 minutes for questions for Dr. Barnes today. So if you do have questions that you want to bring up, this is a fully interactive presentation. Just post your questions in the comments and we will ask them during our break. But Dr. Barnes, want to give you some love real quick. Sherry Gogler Stewart says, Dr. Barnes, I really appreciate your comfort level with the presentation of this style. That's no small task, especially without seeing all of us. So as we knew you would, you're doing a fantastic job. So reminder, put your questions in the comments and we'll do a break in the next 5 to 7 minutes. Continue, Dr. Barnes.
Trying to think of where to go. So Danny, if you could go to slide 21. Oh, that's not, keep going. Next one. Okay. So I just want to talk a little bit about family trauma and the idea that when I was at Cedar, we did a big survey with all of our families that came through in an entire year. And the number was actually much bigger than the N of 260. It was probably closer to 350. And one of the questions that we asked them was, is living with an addict traumatizing, or interacting with someone who's active in their addiction? And 74% of the family members strongly agreed that it was, and 21% agreed. So again, that's 95% of all of the family members that we interviewed said, this has impacted me in ways that I really never understood. And so if you look at those two quotes, the one is a quote from a 20-year-old mom, or a mom of a 20-year-old female young woman who was addicted to heroin. And I will always remember this. I remember doing this interview with this mom for a research project, for the research project that I mentioned earlier. And she said, it's really been overwhelming. I can sit here calmly and talk now, but that's not the same as when I don't know where my daughter is and what's happening. And I'm getting phone calls from somebody on the street saying that she's been beaten and she's been raped. I mean, really bad things are happening to her. And then she said, it's not such a calm feeling when you get those phone calls, or you get phone calls in the middle of the night. I think there must be some sort of post-traumatic stress disorder for families going through this. And that's always struck me, again, in a study where we never mentioned the word trauma, that the family members began to bring that up. And the next one was a mother of a young man, 37-year-old, who has chronic addiction and mental health issues. And I was doing a presentation for Rocky Mountain Health Plan, and the mom said, she was talking about her second son has mental health issues. And she said, however, I see in this segment of the webinar, she said, he's 37 years old, about 25 years into the dual illness. However, I see in this segment of the webinar instead that I've never been diagnosed with PTSD, but what I read and follow along in your presentation, it was like I was being spoken to. And I wrote back to this mom and I said, I was speaking to you. You and every other mom and every other parent who has been, struggling and loving and helping for years, trying to help that person get through. But the process of beginning to take care of yourself. So if you go to the next slide, we'll go through the next couple slides pretty fast, but that idea of, from my research, my dissertation with families of kids that were in intensive care, but the idea of they had the exact same symptoms of someone who had post-traumatic stress disorder. And we tend to call that secondary trauma or vicarious trauma, or as another term that we tend not to use very much, but chiasmal trauma, the idea that just being around trauma symptoms all the time tends to traumatize us. But when we love someone, if you think of the diagnosis in the DSM, it says you experience an event, witness an event, or someone you love has an event that is has the potential for death or serious injury. And so family members will talk about that they are supposed to be working, and they just can't get their loved one out of their mind. They have intrusive thoughts. They wonder if they got to the meeting today. They wonder if they got to their doctor's appointment. They wonder if they took their medication. They have sleep disturbances. They're incredibly hypervigilant to every little subtle difference, because that's probably critical. And so, do I think family members have PTSD? I think that for some cases they do. In some cases they have what we would call developmental trauma. And the next slide, we're really talking about, in my mind, I forgot I even put this slide in there. So often people will say codependency. I'm codependent. And so if we really look at the history of codependency, we know that the term was actually coined by Bill Wilson's wife about being like a co-alcoholic, that the partners, parents, family members of people who struggled with alcoholism often exhibited similar symptoms. And over the years, it's sort of morphed into something very different than that, the idea of we're dependent on the loved one with the problem. And I just want to say that while I really think there are certain things that we would say are characteristics of codependency, that in my mind, codependency is complex trauma. And it's the same as ACEs, and it's the same as what I was talking about earlier. If you look at the two definitions on this page, you will see that they're identical. And so the reason I think it's important is that how we frame things and how we talk about things dictates how we address them. And if people are getting their codependency information from a magazine, and so often I'll see things that'll say, here are the 10 things you need to do about codependency. It's really far more complicated than that. It's really, truly a neurological response. So again, I would open the door to say, begin to look at complex trauma rather than codependency, although they're really the same thing in many cases. And then let's do one other slide before we kind of go for the break. This is, in my mind, the most important. So if we just go through the slide, and it says individuals and family members, because of the consistent experience of fight or flight, or that sympathetic nervous system response of anxiety, family members frequently experience a change in worldview or perception associated with personal vulnerability, safety, and control, not only of themselves, but for the people that they love. And so when we experience that, we have neurological kind of shifts, and we don't have time to go into all of that trauma response and the establishment of trauma triggers and things that would trigger that issue of not being safe or the need to control. And so for anyone who has ever, I guess the only way to say it is, I think telling someone to stop enabling is like Nancy Reagan telling an addict to just say no. It's, unless we're going to teach people how to do that, then telling people to stop it without being fully aware of the physiological response that most people have when they enable. And I think about talking, so many times I've talked to family members, and they say, I know I shouldn't give my loved one money, but it's the end of the month. He shows up I hear a knock on the door, or he walks in the front door, and I think, oh, he's here to get that rent check. I'm not supposed to give it to him. And so as they try to find a way to say no, and the loved one gets angry and frustrated, and they begin to feel anxiety, and their chest begins to tighten, and their throat begins to tighten, and they get scared or anxious, and they give them the check because it's the safest thing to do. And then they start thinking, well, if I didn't give it to him, what if he died? And all of those other things that are very real concerns. But in my mind, those are trauma responses. And so we have to, again, help the whole family begin to understand, how do we get past this? How do we as a family? And so I just want to make sure we covered those slides. I always have too many slides in the presentation, so if you want the slides, just send my emails right there on the screen. Please send me a note, and I will send you the slides and any other information that you're interested in. So I guess we can take our break now.
Great. Yeah, no, this has been, wow, an eye-opening presentation. We're so excited to have you here. We have a couple comments and a couple questions.
Okay.
So we'll just hop right into it. And again, this is a break. We'll still do our Q&A session at the end to sort of wrap up questions and make sure if you have something you want to ask, you can. But I'm going to throw it up on screen. Hey Wars says, how can one approach the chronic relapser? Perhaps a family that was initially willing to engage in some family work, but after multiple relapses decides to be more removed to protect themselves. So that chronic relapser and that family wants to withdraw. What's your advice there?
So, that's really, I think it's a great question, number one. I think it depends on how you're going to approach that person. And if the family is approaching with a very different perspective on, we've been really trying to understand this idea of family healing, and that we're going to be, we really want to engage with you. And again, it depends on how much they're relapsing, if they need to go back to treatment and those kinds of things. But I have seen really remarkable changes when family members say, we're going to get better whether you do or not. And we love you. We want you to be a part of this. We'd like to really include you in a very different kind of work with us that really, I think that the inclusion of that family member really in as a full member of the family. A lot of times that's not the case. It's very adversarial in these sessions. So we'll eventually get to some ideas that I have for that. But I think families really breaking the rule of silence and owning the fact that it's really painful to be in a relationship and to see someone that they love struggling, and to also be struggling themselves. And I think a lot of times that level of honesty is, can we heal together, opens the door to that process.
Great. Thank you, Dr. Barnes. I have a question. A Facebook user also asked, and then I have a question. The Facebook user says, I often use a genealogram to explore relationships and traumas. What specific questions do you use to complete the 3-generational assessment?
So I'm, I have seen very elaborate genograms that are really helpful diagnostic for the therapist, but they are so detailed that they're not very helpful for the family a lot. And so when I'm doing genograms, I'm really looking at a few things. Can we get a thorough listing of relationships, marriages, divorces, who's alive, who has passed, the reasons for their passing, medical concern. I'm trying to think of the right term I wanted to use. Medical concerns, heart attacks, cancer, chronic diseases, scleroderma, virtually any kind of chronic disease that anyone in these previous generations may have had are going to inform us on how. So I'm really just trying to build a model on how did their belief system and how did their coping systems come out of that? So trauma. And so there's a lot of research on trauma that is like cancer and heart disease, and there's all kinds of medical kinds of trauma. So I try to help them to understand that kind of broadening of the concept of trauma, addiction, mental health issues, depression, those kinds of things as well. So those would be the primary areas that I want to assess. And then I want to understand the relationships that people had. What was your relationship with your parents? What were they like? And like, what do you know about, what are the stories about previous generations that may inform kind of our understanding of trauma and our understanding of disease differently. So that I don't get, I want to know what careers people had, socioeconomics, cultural issues, those kinds of things as well. Because I think they influence the whole coping process.
Great response. So we've got a few people asking for your email as well. So I'm going to get that up. It's mike.barnes@foundrysteamboat.com.
Correct.
Steamboat.com. So I'm going to put that on screen right now just for everybody that wants to connect. We also have his website, drmikebarnes.com, that you can connect as well. But without further ado, I'd like to allow you to finish your broadcast and then just keep those questions coming as we wrap things up in the end. We will also have another Q&A at the end. So Dr. Barnes, take it away again.
Okay. So if we go to the next slide, so one of the things that we learned in our research, and it clearly influences how families manage chronic disease, is the idea that perception is, so this is the beginning of the what's called the ABCX model. And then there's the double ABCX model that I use a lot in working with families. And so that idea of, it's not the crisis, Shaw and Holiday said, it's not the crisis that's the problem, but it's the family's constraining beliefs that restrict an alternative view about the problem. And I once had a student, so I used to, when I was in academia, I always asked my counseling students to define why people change. And, they always come up with a bunch of answers. People are sick and tired of being sick and tired and all of those things. And they asked me, and I always say the same thing, that based on this slide, that people begin the process of change when they realize that the problem they're trying to solve isn't really the problem that they have. And so that may seem a bit convoluted, but how we perceive a problem, it's human nature in my mind to try to solve it based on how we understand it. And so if I grew up in a family with chronic illness of some kind and it was never dealt with, then when we experience chronic illness in our family, then we're going to attempt to solve that problem with the only way that we understand how to do that. And so if we can begin to get people to shift, and a very famous anthropologist, Gregory Bateson, wrote I can't remember the name of the book, but this is back in probably the 60s. But he said that the problem with most alcoholics is they spend all their time trying to prove that they're not alcoholics. And that idea that in their understanding, the perception is, I need to show people that I can drink socially. And so they keep putting all their energy into trying to find ways to manage their drinking. And he said the minute they actually shift that perception to, holy cow, I have a chronic disease. I'm an alcoholic. I am never going to be able to drink socially. That the shift in that perception allows them to utilize resources in ways that they never dreamt about because they didn't think they needed them, because they didn't fit their perception of the problem. And so one of the things that I spend a lot of time working with clients on is I love narrative therapy. And so the idea of helping them begin to really look at how are you framing the problem? And in the next few slides, hopefully that'll be more clear. The next slide is really this is, I think, the last point that we kind of made in our research was, if you remember the slide earlier with the black cloud of trauma in the middle, it talked about 3-generation assessment. It talked about the importance of perception. It talked about organization, the rules and roles and routines that families use in order to meet their needs. And then it talked about family lifestyle or family stages, et cetera. And so what we found was that there was what we called a systemic traumatic stress, in that the organizational rules all began to change. They became much more covert, much more secretive. Family members talked about the person with the trauma rather than talking to the person with the trauma. And that they, and I hate this word sounds bad, but it's the right word. They collude in a way to find ways to help that person out, that person often feels left out of the process. Roles begin to change, particularly with addiction, where we have kids being brought into information about addicted parents that they should not have that information, or parentified kids, routines, etc. That we begin to see triangulation, conflict between the parents on what to do to help that survivor, trauma survivor, to help the addicted person at the top. So, one person tends to become enmeshed, another tends to become either distant. We often talk in trauma, when children are traumatized, about a fadeaway father, where the mother tends to get very enmeshed with that trauma surviving child, and the father tends to feel like a kind of the third wheel, and focuses more on work and maybe more on the other siblings. And so we begin to look that there are sibling role changes for the other kids as they begin to not get their needs met. And so if we put all of these things together, that really working with traumatized families and working with families with certain kinds of chronic illness are actually very similar. And so if we can go to the next slide. So this is a great, so when I talked about the idea that the problem that we're trying to solve isn't the problem that we have. So in family systems work, we often say that the problem that brings the family into family therapy is a problem that's caused by the solutions that they have used to try to solve the real problem. And so, and again, it's really important that families understand that what I'm saying is really trying to be as supportive as I can be. So I'm just going to read it. The idea of it's imperative to help families understand that despite their best efforts and despite their best intentions, the solutions that they selected, either intentionally or unintentionally, to solve the problem with the addiction, with the trauma that's accompanying that, has become a new problem that will need to be addressed. And so all of those adjustments being made in that mobile by different family members who have different levels of tolerance for this illness will bring in other problems. Kids having trouble at school, marital problems. In family stress theory, we call these build-up stressors, that if we can't solve the issue that's causing the crisis, that we will begin to see these build-up of all kinds of other financial problems, job losses, and those kinds of things that often bring the person into therapy, not necessarily treatment in that. So, each family member must look at how their changing thoughts, feelings, physical reactions have changed their coping strategies in family and external relationships. So hopefully that makes sense. And so if we can go to the next slide, I'm going to go into, this is what I think families need. And so I'm in the process of building and developing a new family program that will be probably separate from our residential program. We're not exactly sure how this will work, but it's kind of like almost an IOP for families. And it will include the identified client, the person with the chronic illness. And so when you see what I'm proposing, you'll see that these are all very much dealing both with addiction and trauma, because I think they are interconnected in such a specific way. So the first is education and engagement. It's the hardest part, and I've had a lot of people say, no family's going to come to this program. And I said, well, I think it's what's needed, so I'm going to develop it, whether no one shows up or not. And that idea that, so it makes me think of a story. Families ask me a lot, what should we do? And I used to tell them, and I don't anymore. And what I found was that when I would tell them, their reactions would be, in some cases, yeah, that sounds good, I'll do it. And others would be, well, here's all the reasons that that's not going to work. And the others are going to say, we've tried all of that. And we just end up having a not a very helpful conversation. And so one day I was watching a YouTube by Simon Sinek, and he's a business writer, and he wrote a book called Starts with Why. And he said that people tend to ask, people who really want to solve their problems typically ask the questions that seem most logical, but they're not the most important questions. And he said that people will ask, what should we do and how should we do it? And he said most of the time, if told what they should do and how they should do it, most people don't do it because it's missing the important kind of characteristic. And that is the third question, and the most important, is why should we do it? And I think that one of the reasons that many families would not come to this might be that we just don't do a very good job of helping them understand why it's a good idea. Like really expanding the conversation from here's all the stuff you need to do to help your loved one stay sober to here's all the stuff that this family needs to do to heal. And so in that, I envision weekly educational lectures, multifamily groups, weekly family sessions. And I have a series of questions that there's a method of group therapy and working with small groups, and particularly with family groups, that we can begin to implement certain kinds of questions that build on the family's insight. So I think that's the next slide, but don't shift yet, Danny. The second phase would be assessment and integrating insights. And that would be really looking at everything that was in that slide, from the three, doing a genogram and kind of looking at schemas. The work of Jung and schema therapy is really fascinating to me as it relates to how people with trauma, particularly childhood trauma, use these sort of worldviews to keep things the same. I have a whole presentation just on these issues. And then the third one, and this is the last phase of it. And that, again, this is from Figley's book, Working with Traumatized Families. And he and I have written some book chapters for textbooks kind of addressing these questions. And it's what we call the 5 healing questions. And the goal is to help individuals tell their story. And then for everyone in the family to understand each individual's story, and then to write a family story. And the 5 questions are, what happened to me or to us? Why did it happen to me or us? Why did we as a family act the way we did when it happened? Why have we acted the way we have since? And what will we do in the future if something like this were to ever happen again? And in many cases, from a family perspective, that becomes almost like a relapse game plan. And how are we going to talk to one another? And so I think that's, when I think about ending that scenario, I think that's really kind of the most important kind of process. So that's really, I know we're trying to end at 1:30. So the next slide is just, these are all of, these are the questions. I forgot. So think about these questions and how you might respond to those. And the first one is, what's it like for each family member to be asked to engage in this process of self-reflection and ownership of how you've been impacted, not by this guy or this family member, but by the trauma? In narrative therapy, we really find that if we can externalize the problem, that families are much more efficient at gathering around and coming up with solutions. But as long as we have a problematic family member, then they always stay the targeted client. So that's the first one is, so what's it like to be asked to join this? The second one is, what will need to happen before all of the family members will become willing to see themselves as a necessary piece of the family healing puzzle? And in that question, we're really looking at not resistance, but kind of like for those people who don't want to be there, for those people who are taking a wait and see attitude, it sort of makes the covert overt and allows us to begin to talk about this. The third one, how much anxiety, distrust, resentment, fear, anger needs to be resolved in order for you, not him or her, for all of you as a family to begin the process of healing and changing. For how long have you been impacted by addiction, trauma, and the symptoms of both in your own life, as well as your loved one who has this issue or other friends? And then the last one is, how does this experience influence how each family member has coped with the addiction trauma? So these are the questions that begin a process of engaging clients into a family therapy process. And it's not about, well, we're going to heal this guy, but we're going to heal as a group with this person that we love and care about, who we may be really mad at and frustrated with, but that they're going to be part of this process. Now, I do recognize that for a lot of families, they're just not ready to have that discussion. And they're still too angry, they're still too frustrated. And I think some therapy outside of the family environment may be really beneficial for those individuals. But I really think that if we can begin this process of engaging clients and then helping them to kind of broaden their understanding of chronic disease and how it has impacted everyone, really opens the door for family healing. So that's it. That's my the presentation. And any questions or comments, I would love to hear them.
I think I'm muted. Thank you so much, Dr. Barnes. That was a really excellent presentation. I got a lot out of it. And I hope the audience did. I believe there's some questions that Danny's going to post. One is from Sherry Gogler Stewart. What are your thoughts on how we can help the addiction recovery industry be more compassionate where families are concerned? Some facilities don't even offer any support for families at all and reach out to them only for payment. At a presentation I attended last year on family, the presenter said, you meet the family and then you learn why the client is drinking and using. And the whole audience erupted in laughter. As a person facilitating family programming, I see this attitude far too, and I won't fill in her words for her.
I've heard so many interventionists over the years say, I just brought you the healthiest person in this family. And I think there is a general belief about that. So here's how we at the Foundry have decided that we're going to change that process. Every Tuesday at lunch, we have a lunch meeting where our family therapist talks with the other clinicians about what we're learning about the family, how they're responding to the family work that we're doing with them. How do we begin a process of allowing the therapist who's working with that person to not develop that typical, I don't like working with the families. They're the reason this person is here. But we make it very overt, the relationship that's happening between this individual and their family, and that there are two sides to every story, and that, somewhere in the middle it meets. But we don't allow it. To be quite honest, we can't not allow it, but we try not to. And the other thing is that when we're doing the times that we do a conjoint session where the client is going to be doing a session with the family, we include their primary therapist in that session most of the time. We try to, so that the clinical team has support for one another, from one another, but also so that they can then go back and process what are the solutions that have become the problem for this family.
Terrific. I believe there's one other question, and this is from me, actually. Can you explain a little bit more what you mean by the relapsing episodic illness? Because I think that's really important in developing families, developing that new normal to understand that concept.
So I think about, to give a different illness, if we look at things like diabetes and the idea that people will go for periods of time where they're taking their medication and they will be very healthy, and then they will have other times where there's a lot of stress or conflict in their lives, where their lives become disrupted and they begin to fall away from doing the things that they need to do in order to stay healthy, and they have a relapse and they go back into a state of dysregulation of their blood sugar, and that families are then in crisis as they're rushing them to the doctor and getting all these things put together. And so I think it's sometimes easier to look at that, but addiction is exactly the same way. And the idea that people are active in their recovery, they're going to meetings, they're doing the things that they need to do, and then something happens, breakup of a relationship or whatever, and that person begins to, who was it? I can't think of his name. He just passed, Terry. I'll think of it in a minute. But he was sort of one of the fathers of relapse theory, and he said that there are 21 things that happen before a person picks up a drink or a drug, and that there are all of these sort of signs and symptoms that would indicate that this person is in the process of getting ready to go into a relapse cycle. And so the difference between that and more stable illnesses are usually about disability, to be quite honest, that they have a loss of ability or function, and so that's always going to be the case, so the family adjusts to that. When it is an episodic and relapsing form of illness, families tend to be more hypervigilant and controlling as they're looking for those 21 potential things that could happen before the person before that person relapses. So I think the biggest difference is the amount of energy that families put into being able to predict when that next relapse is going to happen, or be looking for symptoms of that, or trying to control for that. So it's just really a completely different kind of coping strategy.
Wonderful. Thank you so much for that answer. We have one last question, and then we're going to wrap it up. Kim Reel asked, how do you suggest that families get support on integrating these new insights, education, and tools into life? Family programs are often so short when change is a long-term process. The identified clients typically have an entire extended aftercare program, whereas families often do not receive this same level of support.
Well, that's the $10,000 question, and that's really what we're trying to do in the development of this. In the development of this model that we're looking at, is how do we do that in a way that extends the period of time. That's why I say it's going to be kind of like a IOP in a way for families. And so I think people can, at this point, if they go to Al-Anon or they go to Nar-Anon or one of the other programs, and really kind of be looking for those individuals that have made significant progress in coping with their loved ones' addiction, people who are doing their own work with trauma and their own issues. That's why I really love, my favorite of all of the programs is really probably ACOA. And I think very few people realize that Claudia Black, I think, wrote the majority of their basic text, and it's really probably the most trauma integrated of all of the programs. So a lot of times in CODA or in ACOA meetings, they'll find other people who are doing the level of work that they're already doing. Our hope is that down the road, we'll have some research done in this model and we can begin to expand it, but it's just in the preliminary stages.
Great. So somebody came in to save the day. They said Terry
Gorski. Yes, thank you.
Terry.
Diana, thanks. Appreciate it. I just couldn't pull that one off my head. So.
Give it to Diane Sanders to know that. Dr. Barnes, thank you so much. I learned a lot from that presentation. I've heard bits and pieces before from you, but I felt that was really integrated, and I love the concept of the IOP families. I'm sure there's a better name,
Sure.
But how great to get support and recognizing the need for support and making that shift. As always, we're so honored to have you present for us. Thank you so much. And Danny's going to give some instructions. We can't forget this.
We can't forget this. I thought this would be good to bring up at this point. And at the end of Dr. Barnes' slides.
A Way Out is a nonprofit, and if you feel so inclined to support us in helping individuals and families who are underserved, lack insurance, don't have the ability to get the care that they need, please make a donation on our website. We'd be most grateful. And we do have 2 more sessions, Wednesday and Thursday, and then a panel discussion at 2:00 on Thursday. And if you're getting CEUs, we hope you will be here for all of those. And if you have any questions about the CEUs, you can email me directly at director@awayout.org. And we'll go from there. Danny?
Yes. So thanks again. Appreciate you adding value today and really breaking that wide open. Great job.
Yeah, thank you all and thank you, Liz, for inviting me. And Danny, thanks as always for your help on this.
Yeah, awesome, man. Good to see you. All right. So
goodbye, everybody.
Yeah, goodbye, everybody. And again, if you want an easy way to figure out how to be notified when we do go live, if you are in the Improving Outcomes from Addiction group, I just want to show you an easy thing that you can do within the group to be notified when we go live. So I'm in the Improving Outcome from Addictions group, and we have scheduled each of these lives. And for instance, this is that's day 3. This is tomorrow's presentation with Dr. Judy Gersel. If you just click Get Reminder, you're going to get lots of reminders from Facebook that will show up in your notification center and hopefully make it easy for you to find this event and be with us on time. And a final reminder, if you are a clinician that wants to get CEUs for this event, Liz already said this, we do need your name and your credentials and your email address in the comment section to know that you were here and you did, in fact, watch this. And at the end of this 3-day event, we will send out a Survey Monkey for you to fill out to finally receive your CEUs. So today was a huge success. We appreciate everyone and their interaction. So many great things. Thank you, Dr. Barnes. A Way Out, such a great organization. Man, we got a lot of great comments from people that really just enjoyed this. So thanks, everybody, for being here. And Liz, we'll be back tomorrow with Dr. Judy Gersel, correct?
Correct.